All right. Good morning, and thank you for attending our Grand Rounds lecture. My name is Rahul. I'm one of the Chief Cardiology Fellows at VCU. I'm pleased to introduce to you our speaker, Dr. Yuxuan Mao. Dr. Mao is an Electrophysiology Fellow at VCU. He earned his bachelor's and master's in computer and electrical engineering from Carnegie Mellon University and worked as an engineer for IBM, where he helped design the PlayStation 3, Xbox, and supercomputers. In search of a more meaningful vocation, he earned his MD at the University of North Carolina at Chapel Hill. He completed his internship, residency, and chief residency in internal medicine at the East Carolina University, while simultaneously serving as flight surgeon and aviation medicine chief with North Carolina Army National Guard. Prior to starting cardiology fellowship at VCU, he was the associate program director for internal medicine at ECU, where he spearheaded efforts in education through simulation and resident research. During his fellowship, he continued to participate in research and was the Cardio Nerds podcast ambassador for VCU. We are grateful for Dr. Mao's expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions, so please submit your questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and at the end of the presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Mao.
Thank you, Rahul, for the kind introduction. Thank you, Dr. Hunley, for allowing me to present Grand Rounds. I'm happy to have this opportunity to talk to everybody about mitral valve prolapse and sudden cardiac death. I have to thank also Dr. Corey Trankel, who really introduced the subject matter to me. And, I just love the fact that it's an intersection of electrophysiology and imaging. So without further ado, we'll start. I don't have any disclosures. And I'll start with a case. This is a real case from a neighboring institution, a 30-year-old female with a history of mitral valve prolapse, symptomatic PVCs, suppressed on metoprolol, presented to her cardiology office due to concerns about her risk of sudden death. She has an identical twin sister who recently survived sudden cardiac death. They both have identical EKGs with T-wave inversions in inferior lateral leads, and they both have similar cardiac MRI findings with bileaflet mitral valve prolapse, mitral annular disjunction, normal EF. And the pertinent difference here is that the sister has a history of recurrent syncope. The first episode was 8 years ago, and the second episode was immediately prior to her cardiac death episode. So the question is, how would a general cardiologist help to risk stratify this patient and perhaps do some workup before referring her to electrophysiology? So mitral valve prolapse actually has been identified as a clinical entity for over 100 years. The mid-systolic click was first described by Cuffer and Barbill in 1887. Then in 1963, Dr. Barlow, which is the gentleman in the lower right corner, described the billowing of the mitral valve leaflets in patients with the click murmur syndrome. And in the same year, Dr. Criley, who is the gentleman pictured in the middle, is credited with coining the term mitral valve prolapse, or MVP. Overall, this disease has a 2 to 3% prevalence in the general population. And initially, it was thought to have a benign course. And in order to put a face to the disease, this is a picture of Carol Barr, wife of Representative Barr from Kentucky, who unfortunately passed away due to sudden cardiac death associated with mitral valve prolapse at the age of 39, leaving behind her husband and 2 children. And her husband has really spearheaded efforts into research into this area. And there's currently funding for NIH grants. So what is the evidence on the association of mitral valve prolapse and sudden cardiac death? Well, in this New England Journal study, Nishimura followed 237 patients with mitral valve prolapse for a mean of 6 years. And he found that the overall risk of sudden cardiac death was low. It was 0.4% over that time frame. However, there were a smaller group whose risk was 10 times higher. And this group were patients with so-called redundant mitral valve leaflet. This study was done in 1985, so they used M mode, and you can see the pictures on the right to characterize the mitral valve thickness. And redundant mitral valve leaflet was defined as greater than 5 millimeters. So in this cohort, the risk was much higher for sudden cardiac death. And this started the concept of arrhythmogenic mitral valve prolapse. So here's a Venn diagram of the mitral valve prolapse. It contains subgroup of arrhythmic mitral valve prolapse or arrhythmogenic mitral valve prolapse. Patients who are prone to things like PVCs, complex ventricular arrhythmias, non-sustained VT, and also sustained VT. Those groups of patients are then further classified as malignant mitral valve prolapse. There's a distinct but perhaps related entity called mitral annular disjunction, which is also associated with adverse outcomes and cardiac death. And we'll go into that in detail a little later. On the right-hand side, just to frame what we're talking about, in the top is an echo picture of parasternal long access, showing the left atrium, left ventricle with the posterior mitral valve, especially that you can see billowing into the atrium during systole. And on the bottom is an illustration of mitral annular disjunction, or MAD, where normally you have the LV basal wall there, lateral inferolateral basal wall, that is directly attached to the valve. But in these patients, there's a disjunction where it's not directly connected. And during systole, you can see that the left ventricular myocardium actually is apically displaced. So what are the proposed mechanisms for sudden cardiac death? So on the right, you can see an illustration showing that first, when you have mitral valve prolapse during systole, sometimes it can lead to mitral regurgitation. And this essentially, the mitral valve prolapse and the subvalvular apparatus acts as a sail, if you would. So during systole, there's traction where the prolapse mitral valve pulls on the chordae, which in turn pulls on the posteromedial papillary muscles. And that, when happening for every heartbeat, chronically will lead to fibrosis and subendocardial ischemia as well. So the stretch induced fibrosis also induces ectopy. So this usually happens in the inferolateral basal aspect of the left ventricle. And as I mentioned before, the papillary muscles are affected as well. The ectopy specifically most commonly are PVCs. These PVCs are the triggers for malignant arrhythmia. However, with fibrosis in these localized regions, you also have prolongation of local refractory period, which leads to R-on-T phenomenon, reentry circuits, and eventually polymorphic VT and VF. And studies have shown that the Purkinje fibers are also a major contributor to VF via increase after depolarizations. Here's another picture illustrating the effects of chronic mechanical traction. Other than the stretch phenomenon, you have activation of fibroblasts, myofibroblasts causing inflammation as well as fibrosis. And that itself will slow down conduction and electronic interactions with myocyte myofibroblasts. These all lead to reentry because of the heterogeneity in the tissues, as well as triggered activity. The end result are ventricular fibrillation, scar-related monomorphic VT, non-scar-related VT, and premature ventricular contractions. So in terms of how to think about a patient with mitral valve prolapse and risks for sudden cardiac death, we really need to think about a sudden cardiac death triangle. So we kind of mentioned the substrate, including the myocardial scar formation. And we also mentioned the triggers from automaticity, triggered activity, reentry. But there's also transient modulators, including hyperadrenergic states. And studies have actually shown that in 50% of mitral valve prolapse patients experiencing sudden cardiac death, there's been some sort of stressful or very emotional event. Now, in the middle are risk factors that we quantify. Myocardial fibrosis, specifically at the papillary muscle inferior basal left ventricle, MRI to characterize stretch in addition to scar, the degree of and location of mitral annular disjunction, echo imaging, again, to characterize the mechanical traction and different modalities that I'll get into later. And it's important to characterize what kind of ventricular ectopy or ventricular arrhythmia the patient has. They further risk stratifies into lower risk types of ventricular ectopy versus higher risk. Other risk factors include bileaflet prolapse, female gender, there's some controversy about that, and also the degree of mitral regurgitation. So back in 2018, Bassel et al. Really came up with this seminal paper on arrhythmic mitral valve prolapse and sudden cardiac death and characterizing the substrates. And you can see on the right here, the biopsy samples showing replacement fibrosis. So in the top row, slides A, B, and C, you can see replacement fibrosis in the papillary muscles right under the mitral valve leaflet. In D, E, and F, you can see the inferior basal left ventricle underneath the posterior mitral valve also has replacement fibrosis. Now, the papillary muscle involvement was seen in all sudden cardiac death patients in this cohort, whereas the inferior basal left ventricular involvement was seen in 88% of patients. And it correlated very nicely with cardiac MRI late gadolinium enhancement positivity, which showed 93% scar in this cohort. So moving on to the electrical aspects. Now, Jerome Jourdain all discussed the common phenotypes of EKG findings in patients who have mitral valve prolapse and experience sudden cardiac death. What they found was every one of them had PVCs in a cohort of 42 patients. And they further divided it down to the location of these PVC exit sites. And posterior papillary muscles was involved in 97% of the cases, and the anterior pap muscle was involved in 72%. And then the apparatus of the mitral valve was also involved in a lower percentage of patients. So this kind of helps us when we see a patient present with history of mitral valve prolapse and we perform an EKG or a Holter or an implantable loop recorder, exercise stress, what kinds of features to look for. So higher risk features include T-wave inversions, especially in the inferior lateral leads, reflecting the traction in that portion of the myocardium. And discussions on the etiology of that have implicated T-wave memory as well as possible ischemia. Frequent PVCs is also a risk factor, higher than 5% is the cutoff. Fast episodes of non-sustained VT greater than 180 beats per minute, as well as multifocal pleomorphic or so-called complex PVCs. And finally, in EP studies, inducible VT is a very high risk factor. On the far right-hand side, you can see examples of T-wave inversions and EKGs showing morphological PVCs from anterior medial and anterolateral and posterior medial pap muscles. So speaking of the electrophysiological study, they can be helpful to further risk stratify patients with other factors, such as imaging evidence of substrate. There's actually no standard criteria for what is a positive study. However, there's proposed criteria, and these unfortunately have low sensitivity, only 44% in one study. So although they're very specific, it's possible to actually miss patients who have previous episodes of survived sudden cardiac death even. Now, moving on to some other risk factors that we can characterize with echo, cardiac MRI, and things like symptoms. So just very briefly, in echo, we look for myxomatous leaflets, thick leaflets, evidence of mitral annular disjunction, bileaflet prolapse, and things I'll go into like pickle help sign, mechanical dispersion, abnormal strain. Cardiac MRI, I mentioned scar, and other aspects include mitral annular dilatation, curling, T1 time, the length of the mitral annular disjunction as well. And one of the highest risk symptoms to look out for is unexplained syncope. Family history of sudden cardiac death is also a risk factor. However, genetic studies have not pinpointed a definitive set of genes. And there's also something new with PET FDG uptake that can detect subclinical inflammation. So going through these different imaging signs. So first is the Pickelhalp sign. So it's basically echo finding in tissue Doppler, where you're looking at the tissue Doppler velocity of the inferolateral LV wall, and especially at the annulus. And the idea is that this is where the most traction occurs, so the velocity would be the highest. And on the right-hand side, you see the first row are echo images of bileaflet mitral valve prolapse. In the second row, you see these peaks on tissue Doppler velocity, 32 centimeters per second, 19 centimeters per second, 25 centimeters per second during systole. That is the Pickelhalp sign. So the Pickelhalp is a German military helmet back in World War I. And it, the echo kind of looks like the helmet. And the cutoff is greater than equal to 19 centimeters per second, and it is 72% specific. If a patient has this sign, their risk of having ventricular tachycardia is double those without the sign. So next up is something we're all familiar with, strain imaging. So with speckle feature tracking, we can measure 17 segment strain parameters and have a bullseye view of the values. So in mitral valve prolapse, because of the traction and elevated velocities in the basal posterior inferior aspect of the LV, those areas will have supranormal strain. So the absolute value of the strain will be greater than 24. So in the picture here, you see they're very high, negative 30, negative 34, negative 36. Now, in the opposite segments, the basal septal segments, you'll have subnormal strain, and that's shown in the pinkish color in the bullseye diagram. So related to strain is something called myocardial work index. It's a measure of both afterload and myocardial deformation. In an overview, normal is green, whereas areas of high work is in red. So it's useful under different loading conditions. And it usually matches and is complementary to strain imaging in mitral valve prolapse patients. The red areas in the bullseye diagram indicates high work state due to repeated traction increases, which increases energy demand and oxidative stress. And that provokes localized hypertrophic and fibrotic response. So all of these are ways to visualize areas of substrate. And then there's still using strain measurements, you can do something called the mechanical dispersion. What that is the standard deviation of the time to peak strain in all of the 17 segments. So in arrhythmogenic mitral valve prolapse, the standard deviation is much significantly higher, 59 milliseconds versus 43 milliseconds. It's a marker of heterogeneous contraction. So now we move on to mitral annular disjunction that we look at in echo or MRI. So this is a controversial risk factor. In earlier studies, it was shown that greater length of the mitral annular disjunction was directly correlated with percent of late gadolinium enhancement and occurrence of non-sustained VT. Now, when you have MAD, what happens during systole is what I mentioned before, which is the apical displacement of the inferolateral myocardium, but you also see this systolic curling motion and basolateral hypertrophy. And this is thought to be associated with progressive myxomatous degeneration of mitral valve and, of course, stretch in the mitral valve apparatus. So despite these encouraging associations found in earlier studies, it's still not clear if MAD is a precursor to mitral valve prolapse or a byproduct of mitral valve prolapse or is completely independent of mitral valve prolapse. There have been patients with one or the other, but not both, or there also have been patients with both. The other issue is that there's no precise cutoff that's been defined to predict risk. So more recently, there's been the UK Biobank population study that showed that any disjunction is actually common in healthy patients. The only uncommon mitral annular disjunction is in the inferolateral area adjacent to the P2 scallop. And this is the only type that's associated with prolapse. So this has really kind of put a new perspective on how predictive MAD is for arrhythmogenic MVP. And then there was a new kid on the block. It's called the double peak strain. This is a study that just came out earlier this year from Nagata et al. And it uses strain, and what it describes is, if you look at the figure on the right, still that mechanical stress motion where the annular expansion occurs, pulling the inferolateral, posterior inferolateral wall, and as well as putting traction on the papillary muscle. But in patients where the traction is so severe that you have a double dip or something that shows up as distinct peaks on your strain, these patients have a tenfold higher risk of developing dangerous malignant ventricular arrhythmias. And they actually compare this with late gadolinium enhancement. And as you can see on the graphs on the left-hand side, they compare very favorably with each other in terms of event-free survival and arrhythmic events. So now we come to cardiac MRI and late gadolinium enhancement. So this is probably one of the most powerful risk evaluation methods for including the following reasons. So the late gadolinium enhancement are typically focal, and they're in the usual areas, including the basal inferolateral wall and papillary muscles. So it's very specific for mitral valve prolapse substrate. The prevalence of fibrosis is between 33 to 63% of patients with mitral valve prolapse and ventricular arrhythmias, not necessarily sudden cardiac death. Whereas in patients with a history of sudden cardiac death, including those who survived them, the prevalence is closer to 93%, as I mentioned before. And it portends an elevated risk of 7.7% of ventricular arrhythmic events compared to patients with MVP without late gadolinium enhancement, which who have a 2.7% risk. So that all looks great, but there are some limitations to how this can be interpreted. So first of all, if you have enhancement, it doesn't necessarily mean that this patient is high risk. Studies have shown that replacement fibrosis is actually common in MVP in patients with even mild MR. It's 25% prevalence in that cohort. And if you don't find enhancement that doesn't mean the patient is not at risk 100% either, because not all sudden cardiac death cases with MVP has fibrosis that's detectable by CMR. And studies have shown that 81% had either microscopic fibrosis or none at all. And this led to the hypothesis that there is subclinical inflammation and ischemia happening prior to scar formation that's not detected by CMR. And that's where hybrid simultaneous PET MRI studies come in. PET scans with FDG uptake is thought to be a marker of subclinical inflammation and ischemia. And in this study, for example, they looked at patients with both PET and MRI studies, and then subdivided these patients into those with complex ventricular arrhythmias or high-risk ventricular arrhythmias versus minor ventricular arrhythmias. And what you notice are several things. So first off, the PET scans percentage positivity are always higher. So that implies to me that it is detecting subclinical inflammation and ischemia in everyone. The second point is that if you look at those patients with higher risk ventricular arrhythmias, the percentages for both PET positivity and PET and MRI positivity are higher. So in contrast, the FDG uptake, relatively speaking, is lower as compared to those with lower risk ventricular arrhythmias, where the trend is opposite. The late gadolinium enhancement is lower, but the FDG uptake is higher. So one interpretation is that the portion on the cohort on the left actually have developed more scar and therefore have higher risk ventricular arrhythmias. And the cohort on the right are still at an earlier phase of disease where there's more inflammation rather than scar, and that's why they have minor ventricular arrhythmias. So that is the very powerful tool to and it's complementary to CMR. So with all of these tools to help with risk stratification, I just wanted to put it all together into an algorithm to risk stratify patients, even if they're seen by general cardiology first. So this is one of the best algorithms I've come across. It's from Mark Miller with Mount Sinai group. So he divides patients into two subgroups first. You have the mild, moderate MR group with MVP, and then you have the severe MR group with MVP. And then he goes into looking at the risk factors. So for example, if you have mild, moderate mitral regurgitation with MVP, but you don't have high risk ventricular arrhythmias, you don't have PET positivity or gadolinium enhancement on your cardiac MRI, and you don't have high risk symptoms like syncope, then routine monitoring is recommended. However, as you move to the right, the risk factors starts to add up. So for example, if you have complicated high risk ventricular arrhythmias or scar or a lot of inflammation on PET scan, then you're looking at the possibility of having a substrate, and you can at that point help further risk stratify by referring to EP for EP study. And if you have syncope in addition to that, you can actually consider ICD implant. Now, the flip side to all of these risk factors is if all you have is frequent unifocal PVCs, that could be potentially a trigger for arrhythmia, but no scar yet, and no higher risk ventricular arrhythmia such as non-sustained VT, pleomorphic PVCs, then the recommendation is to go ahead and do a catheter ablation and reassess. So on the other hand, if you have severe MR, then surgery comes into play. So surgery, which I'll talk about a little bit later, makes sense in this situation because not only will it potentially fix the mitral regurgitation, but it will also remove the traction and mechanical etiologies that cause the arrhythmia in the first place. So I thought this was a very useful algorithm that I came across. And just to kind of dive into management, so when you have a patient who have MVP and presents with symptomatic PVCs, beta blockers and calcium channel blockers are first-line therapy, just like symptomatic PVC treatment in general. Similarly, flecainide, sotalol, amiodarone have been shown in studies to be effective. In general, for PVC-induced cardiomyopathy, catheter ablation has been shown to be superior to medical management. You can see in the graph from paper by Yuan et al. That the p-value is significant for ablation for decrease in PVC burden, whereas it's not significant for medication. Unfortunately, the story is quite different for catheter ablation for mitral valve prolapse. And I show here a series of catheter ablation outcomes, including the recurrence of PVCs, need for recurrent repeat ablations, recurrent VTs, and overall success. And the reason for the lower percentage of success include the fact that the catheters, it's very hard to maintain stability while ablating structures, dynamic structures such as the papillary muscle. This group of patients have a much broader substrate of abnormalities compared to the bread and butter PVC patients. And they tend to have disease progression with new foci of ventricular arrhythmias with very high rates of late recurrence. So overall, long-term success rates have been low, and some studies have reported as low as 57%. And in terms of mitral valve surgery, yes, it conceptually, reverses the process of mechanical stress. And in case reports and case series, some of those have shown good outcomes. However, because of the lack of higher quality studies and heterogeneous patient populations, some patients who undergo mitral valve surgery did not have a better outcome in terms of reducing PVC burden. And it's not clear that for patients who have reduced PVC burden after mitral valve surgery, if they actually have lower risk of sudden cardiac death. So currently, the indications for mitral valve surgery for MVP involve the degree of MR, such as severe symptoms, degree of LV dilatation and dysfunction, or presence of secondary factors like atrial fibrillation or pulmonary hypertension, and whether the valve is suitable for repair. So the jury is still out on that. So with this overview, I like to just go back to the case. The patient was asymptomatic despite having a twin sister who suffered cardiac death. She did not have late gadolinium enhancement on cardiac MRI. Shared decision-making was performed, and discussions on pros and cons of ICD implant was carried out. Although it was reasonable to do due to the uncertainty in the situation, the recommendation was to have a loop recorder implanted. The patient agreed to have that done and has not had any malignant arrhythmic episodes so far. So with that, I like to wrap it up and get to the questions. And I also like to thank all of the cardiology attendings who put up with me in the last 3 years as a general cardiology fellow. I really appreciate you taking time to teach me everything. And I always say I am the fellow because that I am today because of your teaching, and I appreciate that I work with such an inspirational group of mentors, and it's really been a dream come true to stay here and continue my training in electrophysiology. So thank you, everyone.
Yuxuan, what a wonderful presentation. I mean, it was just magnificent and clear and thoroughly covered, and an excellent review. Just a quick question from the perspective of the MRI that you talked about. Lately, we've been using these maps, T1 maps and T2 maps, to try and identify, particularly the T2 maps, areas where there's excess water in the LV myocardium that would be associated with ongoing inflammation or injury. And I wondered, in your review, had you found any associations of increased LV myocardial T1 time, T2 time, or something we call extracellular volume fraction when you were doing your review? And it was just beautifully presented.
Thank you so much, Dr. Hunley. You know, I have to be honest, I glossed over the studies that looked at the T1 and T2 mapping. So I don't actually know the answer to that question. But it'll be interesting to look into that. Dr. Hunley, I think you're muted.
Yeah, we're very fortunate. Just saying, fantastic job today, and we're very pleased that you elected to stay with us, and fortunate to have the opportunity to work with you.
Yeah, absolutely. The feeling's very mutual. Thank you.
Thank you, Yuxuan. That was an excellent review of mitral valve prolapse. I have a question with regards to your thought about inflammation being one of the drivers for progression of fibrosis and ventricular arrhythmias. In your review, have you come across any treatment that can reverse this inflammation, like any anti-inflammatory therapies that can work to reverse the progression?
Yeah, that's a great question. I didn't come across a study specifically looking at anti-inflammatory agents for mitral valve prolapse. And although I do wonder if anyone's looked at post-surgical patients, if they still have positive PET uptake as much as pre-surgery. That would be a great thing to look into.
Yeah, that'll be a great study. We have a couple of comments in the chat. Dr. Naz says, Thank you, Yuxuan, for the excellent and thoughtful review. Has physical activity been shown to increase arrhythmia risk in suspected arrhythmogenic MVP patients?
Yeah, so that's a great question, Dr. Naz. Again, I am not certain that there's a lot of data in that arena. What I do know is that exercise testing is a reasonable modality to look at PVC burden after exercise or during exercise to see if patients have more pleomorphic PVCs or this non-sustained VTs or something more dangerous. So it would seem like in a subgroup of patients with MVP that it would take more stress to do. And like I mentioned in my talk, 50% of patients who experience sudden cardiac death that occurred during stress, some sort of stress. And, I know there's been a lot of intraneuromodulation for something like this, but also that has not been looked into for MVP specifically.
Thank you, Yuxuan. There's one more comment from Dr. Abuzaki. He says, "Great job, Yuxuan. So proud of you."
Thank you. I appreciate it.
All right, Yuxuan. Thank you so much for taking the time. Excellent overview again. If anybody has any more questions, please feel free to email me or Shannon Winston. Thank you for joining us.
Thank you.